Okay, it's another fine day that I would like us to look at another issue here, another eye condition that is called cataracts. We said in our previous presentation that glaucoma is the leading cause of irreversible blindness, but when it comes to cataracts, this one causes reversible blindness. So in our previous presentation, we talked about glaucoma, and we said it causes irreversible blindness. But today we want to look at cataracts, which causes reversible blindness. So we want to see what is all about cataracts. This is just a normal human eye with a normal palpebral fissure. Palpebral fissure. Palpebral fissure is just the opening of this eye between the upper eyelid and the lower eyelid to allow light to get into the eye. So we call it palpebral fissure. The measurements of the palpebral fissure from lateral to medial aspect is about 28 millimeters to around 30 there. That is the measurement from lateral to medial aspect. Then from the upper eyelid to the lower eyelid, it's approximately about 9 millimeters. But there's always a range. So the more important thing is to understand that this opening is what we refer to as the palpebral fissure. We will not go into surface anatomy of the eye. That can be preserved for another session. But we just want to refer to this eye structure. We said in our previous presentation that we shall occasionally use this diagram here in majority of explanations when it comes to eye issues. So we'll go back to what we refer to as our optical system of the eye. Optical system of the eye. And what is the optical system of the eye? It's just a set of ocular structures which are transparent. The word is transparent. And also structures that play a role when it comes to refraction of light. Refraction of light is just bending of light. Remember, in optics, when light passes from one medium to another, it bends depending on the refractive index of those respective medias. So the optical system of the eye, we've said, is a set of ocular structures which are transparent and they allow light to get into the eye, and they also do refraction. So what are these structures that form the optical system? There are 4. These structures are 4. Number 1, we have the cornea. Number 2, we have what we call the aqueous humor. Number 3, we have what we call the lens. Number 4, we have what we call the vitreous body or humor. Can use these two words, they are acceptable. So these 4 forms the the structures that form the optical system of the eye. All these structures are transparent in order to allow light to get into the eye. Meaning, if you have any opacification in any of these structures here, then that means light won't be able to get into the eye and therefore you'll not be able to see. So there is something called visual axis of the eye. The visual axis of the eye is from the center of the cornea all the way to the macula, the fourth pair there. That's the visual axis of the eye. Then the anatomical axis of the eye is an imaginary line just from the center of the cornea all the way to the central point of the eye, the globe. So there are 2 different axes. So this part you see here is the cornea. That forms the first structure of the optical system. This space here we said is occupied by aqueous humor. That is also one of the structures of the optical system. Then from that we come to this transparent structure you see here, which is the lens. And then here, the space you see here is called the vitreous body. So it contains the vitreous humor. So those are the 4 structures that form the optical system of the eye. That is the cornea, the anterior chamber which contains the aqueous humor. Then we have our lens here and the vitreous body. So for you to see, light must travel all the way through these structures to this point here, the macula, where we have high concentration of photoreceptors, which picks the light signals and transduce those light signals into an electrical potential that is then picked by the optic nerve and taken all the way to the brain for interpretation. To the brain particularly, the visual cortex, particularly at area 17. The other time when we were looking at Brodmann's classification of the brain, remember we mentioned that the primary visual cortex is particularly at area 17. So for you to see, light must get through all these structures up to the retina, and that's when they'll be converted into electrical impulse that is taken to the brain via the optic nerve. So the function of converting light signal into electrical signal is done by the retina. This yellow layer you see here, that is where we have the photoreceptors, the cones and rods. And you know energy cannot be lost. You can just convert from one form to another. Energy is never lost. So that's why light energy has to be converted into electrical signals. For it to be taken to the brain for interpretation. Remember, the nervous system understands only one language, and that is electrical language. So that forms the optical system of the eye. So light gets into the cornea all through the anterior chamber, through the lens, through the vitreous body up to that area. When there is any blockage on any of these structures, then light will not get there. If light will not get there, then it means you will not be able to see. So this is the main culprit. This is the lens here, is the main culprit when it comes to cataracts. We shall see. So this diagram illustrates how light travels from external environment through the optical systems all the way to the retina for interpretation. If there is any blockage at any point here, then your light will not be able to get through, and then vision will not be possible. Okay, so what is cataracts? And you are saying cataract is a common, generally progressive eye condition, and it is usually defined by the opacification or clouding of the eye's normally clear natural lens, which obstructs the passage of light to the retina. So there are keywords here. There is the word opacification, this one. There is this word clouding. And then there's lens. Then there's obstruction. So the lens, once they are obstructed, then light will not get through. Remember, lens, this one here, lens is one of the optical, the structure that forms the optical system of the eye. So the issue is all about clouding, either clouding or opacification of lens. Therefore, light will not get into your eye. Therefore, you will not be able to see. So these diagrams illustrates a normal lens and a clouded lens. So with a normal lens, this is what you see. It is somehow transparent. You can see a red reflex if you do examination using a fundoscopy. Fundoscopy, we shall see. When you do fundoscopy, you will be able to see the red reflex in a normal lens. But in a lens that is clouded, you can't see. You'll see just whitish. So you can suspect cataracts just by doing fundoscopy examination. Still, this one shows us what a normal eye looks like and how an eye with cataracts looks like. With a normal eye, the lenses are clear and transparent, but in a clouded lens or opacified lens, you can see light is scattered. Light is scattered. So it's meeting obstruction within the lens. So in fact, this is gradual now. So this patient will not be able to see clearly. Progressively, it starts slowly and then it progresses. So a normal lens looks like this, and a clouded lens looks like that. In a normal lens, light is passing through. In a clouded lens, light is obstructed and it is scattered. So that is how it looks like. This is another diagram to show how a cataract will look like. When you look at these two eyes, this and this, the difference is obvious. You can see whitish pupil right here, and here you can see a black pupil with the reflex at the center right there. So this is the eye that has cataract, while this is the normal eye. So a cataract eye will appear that way, while a normal eye appears that way. Still, it shows in different dresses of people with different skin colors, and still this shows a cataract because the opacification on the lens is obvious. So pathophysiology. Pathophysiology is just the changes in functional and structural functions of an organism due to a disease. So how does those changes and structural or functional changes come about in cataracts? So we have a number of mechanisms that can give you, that leads to cataracts. There is what we call denaturation of proteins. There is aggregation and coagulation of lens proteins, what we call the crystalline proteins. So when there is denaturation and aggregation and coagulation of lens proteins, then it will change. This is more of physiological issues. The lens proteins, what we call the crystallines, are very delicate type of proteins and very vulnerable to any physiological changes in terms of metabolism, and they are supposed to be clear. That clarity must be maintained. If there is any metabolic activity that interferes with the nature of these proteins in the lens, then cataract occurs. So what you need to know is that proteins, these proteins, what we are calling crystallines, are very special proteins in our lens. So with these changes, your lens will lose transparency. And when they lose the transparency, light starts scattering. We have other issues that can contribute to changes on our lens, and that is oxidative stress. Oxidative stress is just something to do with the production of what we call reactive oxygen species. We have, during metabolism in the body, because our body undergoes metabolism all the time, which is just breaking down of molecules or building up of molecules in what we refer to as catabolism and anabolism. So during metabolism in the body, we have what we call reactive oxygen species. An example is hydrogen peroxide. Another one is hydrogen, what we call hydrogen radical. Another one is superoxidase. Those are just examples of reactive oxygen species. These molecules are produced during metabolism in the body, and when they are produced, they are very, very reactive molecules, very reactive. And if they are released unchecked, they can react with other molecules on the lens to damage the natural, normal structure of the crystalline proteins that we have already mentioned about. So we normally have what we call antioxidants in the body. Example of antioxidants is vitamin C. vitamin C. Another one can be glutathione. So these are some of the natural antioxidants that are produced to counter these reactive oxygen species so that they don't produce damage in the body. But whenever there is excess production of these reactive species, it can overpower the available antioxidants, and therefore we get what we refer to as oxidative stress. It means the reactive oxygen species have overpowered the available antioxidants. Therefore, the tissues are undergoing oxidative stress, and therefore they will go on and produce harmful molecules within the lens, which can lead to opacification of our lens and cause what we are referring to as as cataracts. So that is what oxidative stress means. Can also have ionic imbalances, can have cortical hydration, among others. So cortical hydration is just overaccumulation of water in these proteins, in these crystalline proteins in our lens. What are the causes and risk factors of cataracts? One is aging, what we refer to as senile cataracts. Can have metabolic issues. Can see we are mentioning diabetes mellitus. In diabetes mellitus, this one, in the body, there are some cells which don't rely on insulin for oxygen uptake. I repeat, in the body, we have some cells which not necessarily require insulin for glucose uptake. Remember, diabetes itself is a condition where there is maybe failure in insulin or no production of insulin, or cells are non-responsive to insulin that is produced, depending on the type. But I'm saying, or we are saying, that in the body we have other cells that don't really depend on insulin for glucose uptake. Some of those structures is the lens. So the lens do not require insulin for glucose uptake. So what normally happens is, in diabetic patients, whenever there is high blood sugars, there will be a lot of accumulation of glucose in the lens. As much as the other tissues are suffering hypoglycemia because there is no insulin, or there are issues in insulin sufficiency in terms of uptake, the lens are accumulating glucose, because they do not necessarily require insulin for uptake. So in diabetes, there will be a lot of glucose into the lens. And when it accumulates, it will be converted into sorbitol. This sorbitol does not exit the lens easily. So what happens is, it will change the osmotic status of the lens. And once it changes the osmotic status of the lens, then that tissue will be able to absorb water or draw water from the neighboring structures into the lens. So water will be drawn into the lens because there is osmotic change. There is osmotic change in the lens due to accumulation of diabetes that has been converted into due to accumulation of glucose that has been converted into sorbitol. So this sorbitol changes the osmotic status of the lens, and therefore the lens draw water from the neighboring structures, including the aqueous humor, plus other nearby structures, which will now cloud this lens, and therefore will not be able to see it. That's why we are saying metabolically, metabolic disorders such as diabetes can also give you cataracts. So we have said aging, metabolic issues, there's also trauma. When you hit someone, can also, on the eye, it can also cause cataracts. We have issues of medications, particularly long-term use of corticosteroids. And then we have environmental issues such as UV radiation exposure and smoking. UV radiation contributes to issues of reactive oxygen species. These lights can stimulate overproduction of reactive oxygen species. So once these ones are produced, they cause what we call oxidative stress, what we had explained earlier, therefore contributing to cataracts formation. We have other issues we call congenital cataracts. Children can also be born with cataracts, basically because of some infections such as rubella viral infection, plus other metabolic disorders, and even what we call inborn errors. Inborn errors. An inborn error, for example, where a child is born with inability to digest some monosaccharides, for example, galactose. If a baby is born with an inborn error, maybe lacks an enzyme that breaks down galactose, then it will also accumulate in the lens to form galactitol. Galactitol, which also behaves like sorbitol. It's also a highly osmotic substance which does not leave the lens easily. It causes osmotic change, then draws water into the lens and causes clouding. That's why we're saying congenitally we can also have issues to do with cataracts. Then we have other issues like uveitis, glaucoma, high myopia, among others. You can classify cataracts depending on age, anatomy, maturity, or etiology. Etiology is just the cause. So with age, you can have congenital or developmental. Anatomically, you can have nuclear, cortical, or subcapsular. This is where the nucleus of the lens is affected. And in cortical issue, this is where the cortex of the lens is affected. And when you talk of subcapsular cataract, is a opacification that is beneath what we call the posterior capsule of the lens. Posterior capsule. When you look at the lens are usually in the middle, then you have a capsule and a capsule. This is the anterior capsule, and this is the posterior capsule. So when we have a opacification around here, that is what we call posterior subcapsular. Subcapsular. So when there's opacification beneath the posterior capsule, we get posterior subcapsular cataracts. You can also classify cataracts basing on the maturity, where we have mature, or mature. So etiology we have already mentioned. Then we have types of cataracts. We have already mentioned we have nuclear sclerotic, where the nucleus is affected. We have the cortical, where the cortex is affected. Then we have posterior subcapsular, where there is opacification just beneath the posterior capsule. Then we have traumatic, which is due to an injury. Can also have due to secondary issues, such as secondary due to ocular diseases such as uveitis, among others. So this still shows us types of cataracts. When we have a cortical cataracts, this is how it appears. It appears something like this. You can see some things like a sprocket like this. So when you do a fundoscopy examination, you are likely to see this kind of thing. Then the type of cataracts you will be dealing with is just cortical. Then you have congenital, which appears like that, nuclear. This one is due to secondary issues. Then we have traumatic and posterior subcapsular, as you can see. So how do these people present? How does a patient with cataract present? There is sometimes gradual painless decline in visual acuity, then glare and halos around lights. This affects drivers mostly. They are not able to tolerate bright light from an upcoming vehicles. They see, for example, halos, some sort of rings around the light. So that's what we call flares and halos around lights, especially when you're driving at night. People are photophobic. People have what we refer to as increased nearsightedness. And then we have people can also present with fading or yellowing of colors, monocular diplopia, frequent changes in prescription of glasses as well. Those who use spectacles, you better check frequently because this is one of the possible presentation of cataracts. How do we diagnose cataracts? We do a slit lamp examination. We also do a red reflex test, and then we also do a frontal view. So this is all about ocular examination. Ocular examination. Shall see some of these tools, how they look like and how they are used when you are doing examination of the eye. So diagnostically, we use a slit lamp. Can also do a red reflex test, particularly during fundoscopy and fundal view. You look at the fundus, how it looks like. So this is the slit lamp. This equipment you see here is what we call the slit lamp. So the doctor sits at this side and the patient sits on that side. So you visualize through these eyepieces. There are eyepieces here. They have magnification glasses inbuilt inside here with the different power that enables to magnify and visualize the eye. So this is the slit lamp. And this demonstrates how a slit lamp is used. The patient sits here. You can see this is the patient. You position your head on the chin. There's something called chin rest down here. So the patient positions the head. The chin rests on the chin rest down here. And then the forehead is usually supported by what we call the forehead rest. And then the patient holds the handles. You can see there's a handle here, there's a handle on the other side. Then the doctor sits on the other side. He looks through the eyepieces as he adjusts what we refer to as the joystick, as he tries to focus the slit on the eyes during examination. So this just demonstrates how the slit lamp is used when we want to examine the eye. Then this one is an ophthalmoscopy. Is an ophthalmoscope. Ophthalmoscope. This one is what we use to examine the fundus. This gadget here is called an ophthalmoscope. It's the one we use to examine the fundus. The fundus is just the posterior surface of the eye when visualized through this gadget here, the ophthalmoscope. You can see it has parts. It has a brow rest, it has a viewing window down here. Then we have a diopter diode, this one to adjust the power of magnification as you visualize. Then this is the diopter power display. So as you dial your diopter power, it is displayed here. And then you have an on and off switch here. Of course, you have to put it on first. Then you position your patient at an arm's length first, arm's length from here to here. You set your diopter at 0. Then you examine through the viewing window here. Make sure this part touches on the brow, what we are calling the brow rest. Then you position the patient at arm length, that distance here roughly to start with. Then you set your diopter power to 0. Then you examine through the patient and then target to see the red reflex. Then you reduce the distance gradually as you maintain focus on the red reflex, as you also adjust the diopter dial to get proper view. So that one also is the diagram now, illustrating how an ophthalmoscope is used. Remember, when you are examining the left eye, you must use your left eye. And when you are examining the right eye, you must change the ophthalmoscope to the right eye. So it is right eye to the right eye, left eye to the left eye. That is the order on how to use an ophthalmoscope. So when you do an ophthalmoscope, these are the kind of things you will find out. In a normal patient, you see the red reflex. Red reflex is a reflection of the fundus. We call it red reflex. It is a reflection of the fundus. The fundus is the posterior aspect of the eye, which is reddish orangish. So when you visualize through an ophthalmoscope, you will be able to see a red reflex in a normal patient. But if there is opacification, then you will not be able to see the red reflex like this one, but instead you will see a white appearance. So if you see a whitish appearance, then it means there is no reflex from the retinal wall. Therefore, you are likely to be having cataracts. So when you do an ophthalmoscopy, remember ophthalmoscopy is the same as fundoscopy. Ophthalmoscopy and fundoscopy refer to the same procedure. Just same procedure. Same. So when you do a fundoscopy, in a normal eye, you see a red reflex, and that is normal. It means your light is getting onto the retina, and that is the reflection. But when you do a fundoscopy and you see that whitish color, then it means you are dealing with an issue which is most likely a cataract, though there are also other causes, but mostly cataracts. This is how the fundus look like. When you do a fundoscopy, you see this this is what we are referring to as the red reflex reflection. So what you are seeing in the pupil when you are doing a fundoscopy is a reflection of these structures here. So the behind, or actually the posterior aspect of the eye looks like this when examined through an ophthalmoscope. There is a macule or a fovea. This is where we have high concentration of photoreceptors. And at the fovea is also the center of what we refer to as the visual axis of the eye. Here there is an optic disc and an optic cup right there. Then from there all the way to the brain, we have our optic nerve. Here we have the arteries, and here we have the veins. So that is what you simply see when you do fundoscopy. How do we treat cataracts? We just do a surgery to remove the opacified lens and replace with artificial intraocular